That was probably one of the few things I did.
Back in, say next to walls.
Ran the coalition, so our council, a big council, right? The council that they're working there back in the day.
Yeah, and I can.
Actually kind of began
My
my
introduction is very simple. And then I just kind of
Hi, folks.
I know.
good stuff.
Okay, so we actually are live streaming this. So we've got the live stream going for the folks who are out in the audience. So we're going to get started.
I was not. Are you going first?
So thank you. Thank you. Welcome.
Things the state is doing.
Welcome, and welcome to Philanthropy New York. As those of you who know me, I am Michael Romali. I run the public policy programs here, and I help run our health policy working group. And you're wondering why I'm speaking into this microphone when there's hardly, there's only a few of us here in the room. That is because we are live streaming this, and it's not to pick up amplification in the room. It's not to amplify in the room, but to pick up the sound for the folks out there. So when we get to talking with the panelists, I will ask you to speak into a mic and hand it down to each other. So please remember to speak into it later on when we get to that point. So my job is only to welcome you and to introduce Irfan Hassan, who is our moderator today. Does everybody know Irfan? Should I even bother? For those of you who are out in the audience, Irfan Hassan is the Senior Program Officer for Health and People with Special Needs at the New York Community Trust. He is also a highly engaged member of our Health Policy Working Group Planning Committee and has been essential in helping put together this program today. So I'm going to hand it over to you, Irfan. Thank you very much for moderating today, and I look forward to hearing from you and these wonderful panelists.
Great. Well, thank you. And I guess we're an intimate group today, so I'm going to actually start with maybe we'll just go around and say who's in the room, and then we can get to our speakers who I'm just thrilled are here. And thank you. So, I'm Irfan. I'm with the New York Community Trust, and it's a little weird to be on this side of the mic when I'm usually on that side.
Brian Bird from the New York State Health Foundation.
Michael Now from New York.
Tracy Gardner with the governor's office, Governor Cuomo. The
We
second one?
thought it was a different code.
The second one?
Gary Belkin, New York City Department of Health and Mental Health.
Great. Well, thank you. We're hoping this will really be a session where we can have some conversation as well. But just to set the stage, I think everybody here knows that there are fairly important changes happening in national, state, and local health policy, all linked to the Affordable Care Act. Those of us that fund in primary care, behavioral health, social services, are quickly learning the complexity of healthcare reform and trying to become well-versed with all this new vocabulary and all these new acronyms, DSRIP, PPS, everything else. And it's complex, it's challenging, but I think it is a really, really interesting time as well to think about what's happening in mental health. Our goal with today's session is to continue the discussion many of us have already been having on this topic with some key government partners. And I think we recognize in the world of philanthropy that while we can do certain things, our partners in government are very, very critical to what we do rolling out. And we'll start today with just a brief presentation by both of the panelists. I'll introduce them very, very briefly, and then we'll get into really a working session with questions and answers and so on and so forth. This January this year, Governor Andrew Cuomo appointed Tracy Gardner as Assistant Secretary of Health. Her bio is impressive, and I I'll just add that of the many health policy-related decisions that the governor has made in his tenure, his appointment with Tracy is probably his smartest decision. So, and as a New Yorker, I am glad to have somebody with Tracy's passion and caliber in such a critical position, and particularly thinking about care for some of the special populations that all of us focus in on. In disclosure, the Trust has supported Tracy's work when she was at the Legal Action Center, and we were very glad that we did, because I think it was leading to some really, really important work. And Dr. Gary Belkin was appointed Executive Deputy Commissioner for Mental Hygiene at the New York City Department of Health and Mental Hygiene in July last year. He's not a newcomer to the challenges of behavioral health, having been part of the HHC system and several other areas, which his bio lists. But I think what is really, really important with Dr. Belkin, and I kind of again in disclosure, I'm part of the Community Services Board, which is an advisory body to the department, is his real commitment to making sure that people with mental health issues, a whole range of issues, whether it is severe challenges to less severe issues, are included in a good, strong fabric of community care. And I think that is really where a lot of our discussion will focus on in terms of where we're moving in this community care. So with that, I think you'll go first, and then Dr. Belkin, and then we can open it up to questions.
It's going to be a really short lead-in. Thank you very much, Irfan. And this is definitely, we started talking as soon as you were one of my first official phone calls and emails and my new email address. And at not quite 3 months into this, I'm still talking as if I still work at Legal Action Center, and I still very much, this public official thing is very much, it's an adjustment, and I'm an advocate. I'm always going to be an advocate no matter where I work, but I will say that is, the lens I keep. And I had a lot of trepidation about this meeting because of, gosh, I'm here, I'm representing administration and blah, blah, blah. But I don't need to do that because I'm too new, and you already know this. There's no way to kind of swallow all of this, or they said drinking at the fire hydrant. That was what it was, or the fire hose. And so, as an advocate whose work as an advocate was largely supported by private philanthropy and by what we call, the edgy grant makers, the grant makers who looked out and saw what was not being addressed and started funding things to help be replicated and to create volume and to ultimately be embraced as public policy. And so that's been my 25 plus years in terms of doing work on HIV, that I've been able to be involved in different kinds of initiatives that private philanthropy would seed and would tout and cheerlead for, and then public policy would pick up as the wise thing to do. So that's probably the most important thing that I can say today, is just keep doing what you're doing. Particularly as we're in this huge landscape change, and just the 30,000 foot view is driving a lot, and to the very serious disadvantage of who it's supposed to serve. At least that's what I'm seeing. In more than 25 years of working in HIV taught me where the systems were broken. And when there's an acute situation for somebody with HIV, sometimes in the early days it was the HIV, but often more than not it was the other siloed issue. And so it's addiction, it's mental health, unaddressed mental health, and criminal justice. And all three of them, when we're not doing them right, rely on institutions, totally suck at prevention, and do better when there's an investment in a community network and capacity, but we almost never do. And that people who are affected by these issues and who have navigated them successfully can be the best at then engaging other people in it. So now we're in this time where a lot of what you know and we know as advocates and practitioners and organizations in the community, things that were called anecdotal, are now going to be supported or can be supported, can be Medicaidized. Commercial insurance is getting it. Like if we pay for this small thing over here, we won't pay for this big thing over here. And so, you know, it's an exciting time. We're definitely in an exciting time of change that's happening from the way things were for those of us who've been around for about 20 years. I joke about having lived between the two Cuomos. I mean, and looking at the change that's happened between the two, like, as an advocate, I was totally excited over the fact that Cuomo 2 is closing prisons. I was excited about Medicaid redesign. I was excited about the kind of serious push to resource community engagement instead of warehousing people. That was all happening under, or basically unfolded out of the vision of an executive of this state. And you've got to, that's where it needs to start, and you know, that's where we are. So, you know, in terms of behavioral health, I think for a lot of us who grew up and saw how to address behavioral health issues in the wrong way, right? And I know Dr. Belkin's going to talk a lot about what we used to do that wasn't so good and what we've so much improved on, about the intersection. Remember that horrible, I still think it's horrible term, MICA? Like I just, but you know, that whole notion of a MICA person, like that's the double effect. Throw in some MDR, TB, and HIV, and you had a veritable typhoid Mary or John, right? So, but this issue that there were these siloed systems. So mental health issues were addressed here, and chemical abuse issues were addressed here, and HIV, and it's all the same person. And it's and that they did time, or that they kept revolving in and out of Rikers. And you know, we have a robust Medicaid system that helps us to see kind of from birth to death how people traverse the system, and I think that it's a lot of that data that's also told us just what we, you know, were, I'm not gonna say, I don't like to say wasting money because people needed the services, but the approach, the care wasn't being managed. Now, I definitely grew up, managed care was supposed to be the big boogie monster, but managed care in its kind of non-venal connotation is kind of the best thing that we can try to put forward for folks who have been pushed and pulled into responding to silos when their lives need to be addressed more holistically. And so, you know, and then there's also a bigger recognition of the impact of behavioral health on general health. You know, if you're not addressing somebody's medical or health regimen around their diabetes and they're actively smoking crack, you're not going to get good outcomes on either side. But you can't address those in two separate systems and think that you can make some improvements and not see that person over and over again in your emergency room. Some of the embodying the coverage paying for of behavioral health in ACA was landmark, and that is definitely part of some of the advocacy work that's gone on from my former employer and other folks who have been trying to make this case all along, that you need to address behavioral health issues the same way you address physical issues. Parity to provide the enforcement. So you've got the reimbursement, you know, the carrot and the stick. And so having mental health and addiction parity means that if you don't do it, that you're going to be at peril for some kind of penalty, and just really trying to bring that together. And that's also something Legal Action Center worked on a lot. Legal Action Center, like, if they didn't hire me, I was going to stop them and force them to hire me. And then kind of our understanding, and I'll go back to the institutions that, we address addiction, mental health, and criminal justice. The stigma that's associated with institutionalization in these three areas alone has done so much harm. And so the fact that there is a growing awareness of the catastrophic effect of unchecked mental illness, unchecked addiction. There's a new, quote unquote, population struggling with opiate addiction, heroin, and marijuana, more powerful than ever. Overdose is a regular part of life, and it just really speaks to what we've got to fix. So last year, as an advocate, before I became a bureaucrat, there were some landmark reforms, for example, by the governor to address the heroin opiate addiction. I can talk to you in the room, and even though the public streaming is not quite intimate, but that was very much about a movement by parents from not the urban areas who said, from some of the very same communities that probably were very stalwart in their NIMBY-isms around things like methadone and what have you, who were seeing their children in the throes of opiate addiction and withdrawal, and started demanding the very things that we've been demanding: treatment on demand, medication approach, address it like a health issue, stop the revolving door. All of the things that a lot of us have been talking about for decades basically happened in a legislative session because of the force and power and of a number of communities who had not weighed in prior. And that's just also kind of what becomes valuable for you as grant makers to support grantees in being able to point out and work with, is kind of bringing people in to the policy advocacy arena in a way that they wouldn't have been before. So harm reduction and families in support of treatment on Long Island and the Harm Reduction Coalition are now working together, right? And those kind of alliances are important. So I'm going to just kind of cheat a little bit and just say that between this year's budget and every budget since Andrew Cuomo's come into office has been about meeting the objectives of the triple aim of ACA, but also in creating better outcomes at more cost effectively and with better networks. And, say what you will, some have said that my new boss has been a bully, but the MRT process was definitely one that, again, grant makers have supported in the past. You bring together the stakeholders, you create the table, you have opportunity to talk, you go through consensus, you bring in the evidence, you look at the data together, and you produce what is coming out of, and what has come out of MRT is really very much grounded in our community habit of strategizing and developing what the community needs. We've done it in so many other spheres, and it's just great that the state figured it out. So, and then everything is on the internet now. No more, remember health systems agencies, remember those big data documents, right? Like I used to just, it'd be right next to my big phone book, the health systems agencies book. Everything is on the internet now. And so what I would point you to is the latest, if you don't have it already, behavioral health managed care transition timeline. And as was discussed in our in the overview for the session, the alphabet soup of issues that are happening right now is absolutely mind-boggling, and they seem to be all coming together at the same time. Like July is, literally, no one can go on vacation. July is going to explode with DISRIP, with HARPs, with PPSs, with blah, 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 blah. And so, and I will just say in full disclosure that I am still learning as I drive in this process and trying not to get in anybody's way. But certainly one of the big elements to continue to look at, and this is literally kind of almost fresh off the plate, is, you know, we talk about things like the health homes, right? And the health homes, I 2 years ago, when I was at Legal Action Center, we were able to talk to the Deputy Secretaries of Health and Public Safety and explain to them that health homes were really well suited to deal with the criminal justice population. And because a lot of the high needs and complexity, complex health and mental health issues were in corrections and getting worse in corrections, and usually came into corrections bad, and that the healthcare in corrections wasn't so great. So, you know, and because people fell off the map in terms of Medicaid expenditures, we couldn't figure out their acuity. We didn't know that actually their interactions with criminal justice were probably making things worse. That guy who's going to detox 26 times probably has also circled through, you know, a three-year bid in state corrections, and certainly through Rikers. And so I say that to say that, you know, best intentions, right? So health homes is kind of the linchpin of what a lot of what we are moving ahead to do. Care management, taking intensive case management and bringing it in that addresses people head to toe, that acknowledges things that we've always known, like housing first. Don't make housing conditional, get them in the housing and watch, they'll get better. You know, those kind of, and how do we Medicaidize housing? Can we, will CMS zap us with a taser? Can we do it? Because we can certainly make the case that it improves health. So we are definitely at the stage where some of the linchpin initiatives need to work well and need the influence and take from probably many of your grantees who are probably at this moment struggling to figure out where they're supposed to be in this landscape shift. And so health homes and the HARPs that are coming up, and a lot of the issues, obviously, where the city is going to go on first, the rest of the state is going to then unfold and watch how the city does things. And that, again, in terms of your grantees and what you want to help them stay aware, help them stay plugged in. Some of the funding that they're going to need, or the support that they're going to need from you, is how to stay plugged in to the volumes and volumes of information and how to make it work for them. And then also who educates their clients, their consumers, their constituency. Because if they're not there playing that role, the folks at the 50,000, 20,000, and 30,000 foot level, trust me, are not taking into account how people who are directly affected by these changes are supposed to understand it and navigate it. You know, other than maybe, you know, the CSSs of the world and what have you. And no one yet, I think, until we get this home and community-based services piece going and really see how you can support peer work, we just don't know how we can build the systems, we can make enrollment no wrong door, but that does not guarantee that people will walk through and they will stay engaged and they will be able to navigate it. It's just, that's for me, fundamentally what this comes down to. So I'm going to stop talking because I just should. And I'm looking to hear what the challenges are that you're seeing, and that public-private partnerships I've seen work incredibly well on a number of issues. And I think that now is the time where they are probably more well received than ever. So just want to keep that in mind and keep certainly me in mind as some potential opportunity for that. So sorry for talking so long. Thank you.
Thank you. And thank you, Philanthropy New York, for hosting this and for shining a light on this topic. You know, I really appreciate Tracy sort of, I like your verb, medicatizing. I'm going to use that. Because that, I think, is a nice thumbnail of what we're attempting here, is to hardwire in different ways of doing things, upstream opportunities, bringing into the mix more social solutions, more community-based solutions, and supporting that. I think the devil is in the details, as we know, in the vigilance, the purposeful vigilance to make it indeed all turn out that way. And so I'm going to return back to that in a bit. But I think one real powerful role of philanthropy at this moment is to try to stack the deck in favor of it going that way, but really being an innovative opportunity and not just a shifting around of some costs in the system. I think there is that opportunity. And we in the city want to really take full advantage of it. And so we've been thinking of it, okay, so what do we want at the end of all this? What do we want on the other side of DSRIP and PPSs and managed care? And so I'm going to describe my version of mainstreaming mental health. And sitting from the health department, the upshot is to think of a public health lens about mental health. Not just a treatment system lens, but really a public health lens. And to challenge the treatment system to be part of a public health approach. And again, that's really a way that I think philanthropy can be a seed and a tipping point and assist in transitioning in that way. So I also appreciate your comment about this shift into a public official role. One thing that really has struck me about that transition is a sense of constantly feeling I don't have enough time. This pressure that I'm really a steward of an office that I want to make the most of while I sit in it. And one of the real opportunities of sitting in it is to be able to talk to audiences like this. So I'm going to take full advantage of that opportunity and push to you to think much more ambitiously about mental health than I think we have. So we're doing this roadmap document that was announced by the First Lady and with the Fund for Public Health in New York and with the Health Department to try to fill a vacuum, I think, which is a vision description of what we want mental health to look like in New York City. And we're responding to the breadth of the burden. So these are a few sort of things we come up with when we looked at some of our data. If from our community epidemiologic surveys of the currently people in New York City who've had depression in their lifetime, that number could fill more than 18 Yankee stadiums. A quarter to a third of public high school students report feeling sad or hopeless. And at any given time, walking outside the door of this building, there are 5% of New Yorkers who meet a threshold for serious psychological distress, which is a fairly well validated proxy for likely diagnosis of a mental health disorder. And 1 out of every 10 mothers in this city, 120,000 births a year. So that's a lot of mothers every year experience depression. And in certain neighborhoods and socioeconomic groups, that's a low ball. That's a way low ball. So if we're going to have a vision for mental health, it really should cover this breadth and to reach what I call the red, to shrink the red. So this is a summary table of something called the Global Burden of Disease Study, which measured the relative contribution of different kinds of illness to disability in the population. And this is the summary of that distribution throughout the world. The US colors look similar. Basically, each color is a different group of illness, and it's the relative proportion that it contributes to measure years of life lived with disability. And the red are common mental disorders and substance use conditions. So it's the biggest color. And but we don't act like it's the biggest color. It is that red means not just diagnosable people, but it means kids who are going to drop out of high school, violence in homes, people who don't maintain a job, parents who are struggling, being good parents, people returning to jail. That's what that red means, a huge cost and a huge social cost. And in disability terms, it's the largest. So our ambition is to live up to the red, to shrink the red. And the only way to do that is with a public health approach. We didn't have, over the last several decades in this country, or more than half, cardiovascular-related deaths and prevent millions of people from having smoking-related deaths and completely alter the curve of HIV. Still work to do, but alter the curve of HIV. Slash infant mortality. Still work to do, but slash infant mortality. We didn't do that by working around the edges of reimbursement policy. We did that through a public health approach, an all-in, all-level, whole-of-government kind of approach. And what we want to put out there with this roadmap is the idea that by looking at this, is the 21st century public health challenge should have a first-class public health approach, an all-in approach, a whole-of-government approach. And so that means a couple of things. So we bent the curve on HIV. We reduced other causes of death that I mentioned through public health approaches by not having it be the worry and business of just a few people, but by spreading ownership around those things, paying attention to how people had access and making it a priority to close them, close gaps in access, of engaging, involving, and embedding community-based strategies, acting early, using better data, and innovating government to be more involved and fully engaged. And so my thinking is that we have to translate what these mean for mental health success. Spreading ownership, it's got to be the concern, not just of what I call the usual suspects, the mental health community, substance use community. It's got to all in. That red shows that these issues overflow those settings. They're in our schools, they're in many community-based organizations, they're in our WIC programs, they're in lots of other places, and who also have to co-own this issue. We have to close gaps in open access for mental health by really reimagining what care looks like and who is a provider. There is no way in our lifetimes we will train enough licensed clinicians to reach that red. So we really have to rethink who are our partners in providing care, community mental health workers, bringing peers in, really rethinking who's a provider and how people access care. In the UK, any citizen can sign on and get on the web and get a CBT for depression. There are lots of ways to get access, especially if we think promotively and preventively. Mental health promotion and prevention is a great investment and a set of skills that can be delivered in very efficient and very cost-effective ways. How people learn self-monitoring skills and coping skills and pro-health skills are things that we should invest more in and we can easily distribute. Working through communities, we often, right now for this roadmap work, we're convening feedback groups of all sorts of stakeholders. And the energy, the thirst of community-based organizations, of faith leaders, of schools, of the NYPD, of having skill sets, because they know they're front line with these sorts of issues, is a thirst we need to satisfy. And think of communities as partners and and having assets to address a lot of proven, particularly early intervention strategies, which is the next point, acting early. We know a lot about prevention. We know a lot about what we can do in the early years of life, and this mayor is building platforms to really succeed in effectively reaching all at-risk parents, all at-risk young families to bring in supports and to bring in interventions we know work. One thing that the health department has specifically been invested in is something called parent coaching, where where parents learn rehearse skills and pro-attachment behaviors with very young children, which can really set a path for life, for health outcomes, for education outcomes, for likelihood of being arrested. And so we need to redesign how we act early, use better data. I think there are huge data gaps around mental health and substance use needs, especially to do actionable policy, to do these things. How can I work through a community and know with them where their need areas are if we can't see them? I can give an example of how in the health department proper we have disease surveillance methods that let us map, often to a city block level, where there's a need. And for example, there's a project underway now to train community health workers in East Harlem to go into housing project clusters to really coach their neighbors in healthy chronic disease behaviors and lifestyle change, et cetera, that was driven by mapping people who had out-of-control diabetes based on community health surveys the health department does. And we were able to hotspot these areas. And in the course of doing that, they found that a quarter of these folks reported having depression. So I could not see that. So I could not deploy community health workers to go to these places to similarly be very effective in assisting them to self-help, to get help, to engage that issue. So we can't have community mental health if we can't see the community. So we need better data and therefore rethink how we get it. So I'm now thinking about all sorts of fun things like crowdsourced information, data mining in unsuspected places, social media, and other city agencies who see a lot of folks that we're trying to reach and assess them. We had a really interesting conversation with city agencies, and somebody from HRA was saying, well, we do these assessments all the time on people. We could add depression questions. And that's a way that we could see better and act better. And all of this rolls up into innovating government. It needs to host, use, seed, accelerate, partner in spreading these things to be the new normal, these things to be the new driver of a real public health approach to mental health and substance use. And that's where the conversation that Tracy opened with of the new levers that Medicaid redesign and DSRIP investments and the ACA, particularly parity provisions, as well as extended coverage, can potentially give us to hardwire some of these things. So I mentioned parent coaching. That should be reimbursed. Pediatricians should be able to screen for maternal depression. These are not hard things and they're not terribly expensive things, but they're hugely cost-effective things. But what I think folks at Albany need to see, what we need to see, is good evidence, good demonstrations that these things marry, that these things connect, that the changes in reimbursement indeed are wisely pointed to these sorts of innovations, that it does in the end both shrink our healthcare costs and shrink the red. And I think that's true, but I think we need to do the work of getting there, and I think smartly directed philanthropy can really fuel that. So that's my spiel, and I'm happy to talk more.
My sense, and I with all respect to Philanthropy New York, I know that they spend a lot of time saying that we want to have a discussion, and we do, and I don't other people want to have more of it. But I think we also want to hear, I do, but know a little bit more from you guys about what the nuts and bolts of what you think you weren't supposed to tell us about in terms of DSRIP and Medicaid redesign and the incorporation of mental health and these things that, like, we want to hear from you about what these changes in government are going to do on the ground that we in philanthropy will then use to respond to. Am I right? People want to hear that, or does everybody
your election.
So what I was going to say to you, Tracy, is with due recognition of the fact that you have not yet figured out how to drink from the fire hose. And so this is sort of unfair in that regard. But just to sort of to field your oats as your public official hat, your public official hat. How do you, and I might turn this to you as well, but let me start here. What do you see? When you came into this job, and you must have had a number of things that you thought would be priorities that were actionable in the time you are. Yes. And then you also probably came into this job and got from others in state government some sense of how they saw what the priorities that were actionable that they wanted you to work on. And I think it would be good to start at the state level to have whatever level of clarity or disclosure on that agenda that you feel prepared to share. And then we might get more concrete at the city level as well, but let's start there. So, again, understanding that you're 3 months into this.
3 months into this and the
And so understood, and we've all had, it's one thing that just to sort of introduce this in that way.
Sure.
Philanthropy New York regularly hosts meetings for funders with new public officials.
Okay.
And we do that, of course, most with the city because they're right here. Right. And we do that always at the beginning of an administration and at other critical junctures along the way. And so it doesn't mean that you shouldn't hold back on things you need to hold back on, but it's also a very different type of audience. It's not a broad public audience. I don't know about the live streaming. I don't know who gets that, but
How funders in funding you, unless you were
right.
But
But I think this is a sort of a middle space there.
Right.
We're not dealing with the
Not
New York
going to
Times.
press.
It's not the public. It's not going on a website.
Okay.
And yet, that said, you're certainly, we'll hold things back. But I think you're early enough that you can get away with talking about your current perception about priorities that are wished for by you, certainly by you, and to some extent from your environment without whatever you feel like.
And what are these changes doing for behavioral and mental health?
Okay.
There's been a lot of talk about them, but let's talk about mental health.
Okay. No, I don't. I'm actually more, I'm more comfortable being candid and in a safe space and, as my teenage son would say, developing better filters. But that's part and parcel. Yeah, right.
You don't say that, yeah.
No, exactly. So that's the challenge here, right? It is true that I accepted the position with an agenda, thinking I can get some stuff done here because I've been working as an advocate, but with partners in the public sector to make things happen. It can happen. It's not glitz and glamour. It's kind of the guts. It's the sausage making. And so I wanted to be part of the sausage making around a number of issues that weren't necessarily ignored, but they were definitely part and parcel of the agenda that this governor came in with to change, to be able to use the bully pulpit, really bully pulpit, to move a lot of inertia, to move a lot of we've always done it this way, and to use both cost savings and innovation and doing things better to get some things that have long been a problem. For me, it's been about addiction, and it's been about criminal justice, and it's been about kind of addressing how much addiction has been parked over here and not pulled in to kind of part and parcel of everything we do when we're approaching a person and their health. It is whether we're preventing addiction or we're treating it or we're supporting the recovery from it is a big, matters to me a great deal. And I saw a lot of that again through the lens of HIV. When you stabilize somebody's active addiction, how other health outcomes improve. I've also felt like the whole discussion about mass incarceration is, for me, an intersection with community health. That everything that we have been trying to do in the last 30 years has been undermined by our policy, our drug policy, and our policy of incarceration, because the health of the men and women inside is integrally linked, is the same health as it is in the communities that we have not invested in. So I also felt like making people clapping heads together to say, the people that you think that you're trying to get, the frequent flyers, the folks that we're trying to reach with the HARPs, they're in prison, they're in jail, and we keep putting them there because we're not doing a good job on the community prevention side, we're not doing a good job on the community stabilization side, we're not working with their families that they go home to, we're not housing them, so we keep throwing them in jail and stuffing them full of pills. So I don't know if I'm going to be around that long. It's not a kind of long-time job. It's a high burnout risk. But I will say that there are, in this second phase, right? So, and that's the other thing, is the overlay of the politics. This governor had to stay around. He came out with a bold agenda, and now we're in the grind of implementation, and with the media scrum and the internet, it's just not sexy. Now, what I have, I saw an article in the New York Daily News that talked about Cuomo's quiet Medicaid miracle. This is not happen. This is not cute. Cranes didn't cover it. Capital New York didn't cover it. But the fact is what he struck out and said he was going to do with Medicaid redesign, and what everybody told him could be done, and New York should do it, he's freaking doing it. He's doing it, and particularly the area around the integration of behavioral health and acknowledging that our sickest people have these complex health issues that are being exacerbated in other settings. And we do it to them as kids, and we do it to them as older adults, but where we're really egregiously hurting them as around the behavioral health issues and the resistance to integrate. So regulatory, financial, policy-wide, this is what I feel like we're in the era of, is bringing public health inside where it should have been all along, Xing out the ways that we have been addressing it that were wrong and made things worse. And so the HARPs, I don't know how it's going to work. You might. I don't know how the HARPs are going to work. I don't know what it means when something stabilizes and they get this kind of cluster of acute services, and then they get better. Do we have to wait for them to get sick again? What are we going to do? I don't know what it means to care manage across health homes when people aren't sharing data, and when an individual has to sign 40 pages of consent for their provider to talk to another provider, same person. I don't know what that means. We delivered the baby health homes way too early, running, we delivered, it's, what do you call it? Neonatal intensive care. Federal share with 90 cents on the dollar. We ran to make health homes happen, but we didn't give it the time that it needed to be able to do what it can promise. And so now we're putting fingers into the leaking holes and building on top of a ship that has holes in it. Did I say that? Mm-hmm. So what do you need to do as funders? You need to know that everything is happening in a really fast way that is incredibly concerning and frightening and terrifying for providers on the ground who have no Medicaid experience, who have not niche reputation, but who are used to being grant funded, doing population-based interventions in care. They don't know where they're going to be in this, and nobody's telling them. And that and everything is supposed to happen with the managed care plans and hospitals who are going to act like the community-based organizations that we invested 30 years to do and be. We're going to expect the big hospital systems to act like a community-based organization. And if the money doesn't flow for these provider networks, people will not do the service. It won't happen. That's what we're having problems with health homes right now. People are not getting the money, and they're not getting the information from the plans. So, shut it down. Is that more like what you're trying to hear, some of the challenges you may want to hear more about? And I can send you to the behavioral health, you're probably monitoring that, but the state is still very much in the beginning stages. We're still waiting on CMS approval for the HARP.
I guess the one thing and that is helpful, very, very helpful in sort of getting into the nitty-gritty, but how do we sort of go from, and our work usually is, you support a non-profit as they're piloting out something. You might do some work in the connecting of two groups that are doing some similar work. You might kind of support some of the data collection. Where do we come in? Philanthropy. Does philanthropy come in figuring out how do you unclog that?
Right.
With short of being the cash tide over, which I don't think any of us can be in those systems. How do we sort of move that stuff? Because I think that's where a lot of us, as we get requests, it's around this. We need the information. We need the process. It's sort of stuck a bit here, happening here. Is there a role for us in that very, very fast-moving process?
I'm just going to say that, again, I'd say about 10 years ago, maybe a little bit more, I started seeing the tables that brought together stakeholders, some of whom had, vested financial interest in kind of policy as it was unfolding. Yes, they did. Like the big hospital systems, the HHCs, like the Ryan White Title II or Title I Care Network. But these tables started disappearing. And what they provided was also an opportunity to get information. So while everyone is wired and online and there are, listservs and what have you, the value of the tables and being able to get information and see people and make those connections about, are you working in Bed-Stuy too? And you're doing what? That has completely disappeared. And what we have now are kind of government agency mandated advisory kind of things that are pro forma but don't allow people to strategize and identify where there are gaps, holes, and problems. That's one of those things. It's not terribly expensive to do a monthly, quarterly, big table update, blah, 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 but it's incredibly valuable. And people don't have that to go to anymore, especially grassroots and smaller not-for-profits who are trying to understand what their role is in this.
So I would say similar things. I think building the right.
I'm not going to be around for much longer.
I think where you guys can make a difference is in building smarter networks that are outside the health system. If a lot of this work is going to shift there, they need help in being smart at planning, at achieving results, and building in the improvement processes to get there. And so anything that builds that capacity and the smart ways for the healthcare system to work with these networks in the community that they're building, because I think they don't know how to do that, would be very helpful. Because it's not, I don't see DSRIP dollars going to building those habits, and that's really would be a missed opportunity. I also, what the city is doing is really trying to get some structures stood up that can fill some of that gap of local planning, and so we are, as are other regions in the state, establishing under the mental health, the managed care statute, something called the Regional Planning Consortium, the RPC, which is a opportunity to bring stakeholders together to try to get early signs of problems and to troubleshoot. So we are setting ours up in a way where there are steering groups defined by stakeholders, but then we form and the department host ad hoc working groups around evolving problems. So for example, the key steering groups are the plans, consumer groups, providers, city agencies, and the health homes. And we've already convened them, and we've asked them, what do you want to start working on? And they tell us. And so we're starting to form some of these working groups to anticipate some startup issues. Another thing of this whole conversation is the thing hasn't started yet. So that's one structure, but it's an important structure, and we really want to innovate it and build it out to both be a very early warning system, to track outcomes that the state is not going to track. But at the end of the day, we really want all this stuff to improve. Social outcomes, other health outcomes. But what is, we convene all the PPSs, all the behavioral health PPSs, and what they also tell us is a real gap is they've created these networks of hundreds of partners, and they are not ready to work with them. And so it's building that intelligence on both ends. The hospital systems.
Oh, yeah, they work with the smaller providers in the network.
And not just providers, but even non-providers. And to me, that's the biggest sort of opportunity is, you know, so as part of this roadmap exercise I was telling you, we bring different feedback groups together. And I was very intent on bringing a lot of non-health, non-mental health CBOs because they see the most of this stuff. And they see the opportunity. They don't have the tools and the connectivity. Right. Right. But they're the credible places for the people we're trying to reach. So.
What's the vision of how the city and state do that? Or are you just setting us up?
No.
No.
So going on.
So we're bringing them in within the structure I just mentioned, but we also want to put out initiatives as initiative ideas and directions out of this roadmap document to build up that whole sector to really be a full partner in mental health. So just yesterday I met with a group like this, and there's one coalition, South Bronx Rising Together, which is just, which has some provider groups in it, but has a lot of organizations that are working with youth, that are working with groups that around non-health at all related stuff, but are very credible to those populations and see the behavioral health stuff right in front of them and want to be skilled up and want to be connected in a sensible chain to other providers, but want toolkits to know what they can do, how they know when to escalate it, and to have those pathways built. And so I think one responsibility of local government is to try to make that happen. And at the end of the day, that is, if we can't connect some of these resources, whether it's through reimbursement or through the district shot of cash, to leave that sort of capacity behind, then I think we fail in a big way.
Well, I would just argue that some of these organizations who are outside of the health and mental hygiene realm, who should be engaged, do not see the merits of pivoting outside of their, contract deliverables. You know what I mean? It's kind of, and if you're asking them to make that pivot, what is the way that you resource them and engage them and really acknowledge that they are a critical part? I mean, this challenge of you've got to have volume or nobody wants to talk to you. I think some of for example, the state initiative around faith-based that the former assemblyman is going to be heading up is an acknowledgement by the former administration that we're going to have to do something very much more out of the box than we're accustomed to in terms of putting through some of these initiatives, particularly around some of the health and social services piece. So that capacity is definitely there. All of the agencies have been mandated to kind of pop up who their community networks are, who their faith-based networks are, and talk about, building data systems that allow for us to reach out to this group. But
so let me be bold and possibly completely right in terms of absurdity. I mean, when I think about challenge of pivoting from advocate to public official. You know, the question is, you know, really here the problem is, you know, making money. I think the agencies that want to have a role, they want to have a pathway and a connection, don't have a lot of the skills, and they don't have the money to build the skills or build the staff, even creative pathway. And the biggies don't know how to work with them anyway, and there's lots of people of them, but without money of any sort, flowing either in the immediate term from Medicaid or managed care, in the longer term from district as an incentive payment, there's really nothing supporting their building capacity in the system yet. We have this vision that these networks are going to function differently in a public health kind of model, in a population health kind of model. So, you know, the lever is with the state. So I say this not to you, but I say it because the state is the real source of power for money. And so, you know, my wish list is, and controls the basic requirements of Medicare contracts. Right. You know,
Well, how we open 9 to 5. Right. No, you can't get it. You know,
so the question is, what's the agenda of what gets into those contracts? What's not in them now? What needs to get in? If we want to achieve this kind of vision, that agencies work together. Right. And some of it is about consumer protection, some of it's about money to smaller players. There's all different kinds of category buckets there. But what are the levers? The levers are the requirements in the managed care contracts. The levers are the requirements for the district payments. The levers are the required metrics that would be creative enough to allow those types of agencies to have something to say or to add.
and what can you
And
yeah.
I mean, so it's identifying the levers and figuring out when, where, how, and to what extent your new environment will give you room to have your advocacy voice from the inside in supporting what ultimately is about regulatory and money support for this vision on the ground.
Right.
And, you know, so it's almost like, you know, I want to say to you, Gary, what's your agenda for her?
Yeah.
You know?
And not as an apologist, but also just to underscore how I get to look at this. So I'm Assistant Secretary of Health for the Mental Hygiene Agencies. I have a colleague, Assistant Secretary for Health, who oversees just DOH and OMIC, right? Enforcement and the monster, you know, and all things continue to, you know, definitely envision the King Kong on top of the Empire State Building and then the planes around. So I'm OMH, I'm OASAS, I'm OPWDD, and still, I mean, even in OPWDD, we have DOH rates, OPWDD rates. It continues to happen solely in the behemoth that is Department of Health. So, you know, what would you want? What is your agenda? Well, actually, Bob Myers told me what your agenda is for me. But tell them what your agenda is for me.
Well, but Bob already told.
Yeah,
and,
you already told. So tell them what.
I mean, a couple things. So I have a wish list of things that Medicaid reimburses for. That would be, you know, I think very cost effective. I mentioned a couple of them. I mean, there are just a lot of practices, particularly peer-driven practices, earlier intervention practices, preventive practices, outside of clinic space practices, that if they were reimbursed, and especially in a value-based purchase environment, if they were considered as part of what would fall into a capitated rate or whatever whatever valuation method is used. So that's one thing, is that we pay for different things, and it, yeah.
Because so many of our providers, again, I don't focus on older adults, we're funding those sort of things. We're funding in a senior center in the north, somebody who's there to help to deal with somebody who's a little depressed maybe, and trying to avoid
Right.
exacerbating, but they are just struggling to keep those
Yeah.
workers
Yep.
in place. And this isn't, I mean, and they're running at, they're let alone all the other stuff. So I'm just, sort of making sure that right now, there's all this good work being done at all these agencies, that about that, and that, it's not necessarily reinventing the wheel, because there's all this
this work being done in the community already. And they need, sort of like you said, they need the dollars now.
Yeah.
Because they're doing it. And there's only so much we can fund.
Yeah. I'm going to add to my wish list, but to address your question, the real challenge from what I said is we don't know the impact of all of that. So I pass through, right? So our agency, we pass through hundreds of millions of dollars from the state for all sorts of stuff, and we don't know the impact of that. So on the one hand, there's this: we'll protect all the people you're currently funding, all the providers that are currently funding because they're doing good work. But I don't know what the impact of that work is. I don't know how, what we need to bolster, what we need to shift, what we need to refocus on. And that's a real, it gets at my, needing better data. So with that challenge in the picture, I still think we can identify things that we know aren't happening enough that would be impactful that should be hardwired into Medicaid reimbursement. Now, another thing that you sort of touch on is, so what's going to shift in terms of what comes from the state to us to pass through to the providers that is now going to be covered under Medicaid, particularly HCBS services. So what happens to the state aid flow, and can we use that as an opportunity to not curtail that flow, but to really use it to innovate and support these transitions and be smarter about it? So that's another thing we would like to do as a local government. So local government would also like the state to have more faith in the local government. There seems to be a lot of faith in a marketplace, the managed care organizations and the PPSs together to sort of figure out what's good for all of us. So that's something that I'm worried about. I'm not the only one worried about it, and there are people in the state who are also worried about that. And we've actually had very good conversations with DOH about how to position our department in a constructive way, working with them moving forward. So they're open to that, but I think that's going to be a key, more than open to that. I think they realize there's a lot of working parts that they're betting on. But I think that's a key thing moving forward is how well that works. Because what metrics can be seen in Albany and what sort of performance expectations can be seen in Albany and what contract enforcement can be seen in Albany is not going to be enough to granularly at the local level identify what impact we're having, how it's affecting providers, how do we shift. Really is a huge, what I put out here in 3 slides is a huge shift. And it's saying some hard things. It's saying to some providers, you need to change what you're doing. We're not paying for that anymore because it's not getting us anywhere. Right. But it doesn't mean there isn't a, your credibility in your community, your experience, your tacit knowledge about your communities is not something we want to evaporate. It's something we want to repurpose. And so how do we make that shift doable? And so that gets back to what I was saying, can the aid flows, help? Can we repurpose them to that kind of transition? And so I think it's really going through our current contracted services and mapping what, the sorts of things that we want to happen and really rethinking at a granular level, how do we shift that?
Is when there are particular services that should be medicalized, but the evidence base isn't strong enough to make the strongest case possible. It really comes down to $100 to say for how many emergency visits to say. The pilot projects or smaller scale legislative projects that help begin to build so that's one kind of area, but we often rely on our own insights and our own partners, but it's very helpful to have local government, for example, feeding those ideas of the types of things that you perceive to be at the top of the list in terms of potential importance and at the top of the list
and for that, local government's changed. So I'm looking at my division as the local government unit for mental health in New York City. Do I have the bench to do that, right? Do I have the analytics to do that? Can I get what I need out of the Medicaid database to know in real time, what the impact of all these things are? Do I have the people who can do cost-benefit analyses? So we're looking at that. We're also looking at other governments that have done this well. So before I came here, I spent some time in Toronto. The province of Ontario has designed its sort of mental health authority to be this kind of innovation incubator partner to communities, to really be the host of self-forming clusters of different voluntary agencies in a city or a town to link together a different way that there's a pathway of kids who are arrested, into care rather than into punishment, and so equip them and sort of host their ability to try best practices and adapt and adopt and spread, and then become this kind of architecture of knowledge sharing and innovation. And so I think we have to look more like that. And so one big idea I'm putting out, and we'll see if it goes through this process, is to create a sort of mental health lab in city government or in our agency that becomes a permanent fixture then. And if we can endow that to a degree to really work on bringing to CBOs who step forward to link up in the ways that we described, that becomes a permanent fixture.
So I have a question. I wasn't clear if you made it all the way through your wish list of Medicaid, what you wish Medicaid reimburses for, and I also was not clear what response you had when you saw that list.
So I forgot what I said, but reimburse for more stuff,
Right.
More local engagement in how this dance between the plans and the PPSs happen. A more flexibility in using this shifting role of state aid to become this innovation incubator and hold the bag of, is all of this shrinking the red? We have to reduce costs. We want to reduce avoidable hospitalizations, yes. But the main worry I have is that the driver vision of this is reduced hospitalization. The driving vision of this should be shrinking the red, should be improving social outcomes. That the mental health system, the treatment system, the care system, these investments have more kids graduating from school, less people in jail, better health, longer life expectancy, less domestic violence. If that's not the prize that we have our eye on, then we're just circling dollars again in a system, and we're not being ambitious about what we want out of it.
So,
And before you answer, can I also add on to what I'd like to hear from you, is that I'm hearing from this conversation that a lot of stuff that's going to happen in New York, which I'm very happy about, is largely dependent on New York City's vision of implementation. So does this kind of stuff statewide equally depend on local actors doing the same kinds of things that Dr. Belkin is doing?
I'm just going to say from my new vantage point that a lot of what Dr. Belkin is talking about in terms of certainly the local viewpoint being informed by what the needs are or should be resourced, should be supported, should be met for that. It's the whole point. The province issue around who gets to tell the plans what to do and how to do it, I imagine, just from thinking about some of the players, and that's, to be very frank, some of it is about the players and the personalities, and I don't know that there is, I don't think there's not a willingness. I think that it's just new. It's a new prospect, and so what's new is uncomfortable. And don't tell me how other states do it, or don't tell me the state how other states do it. In New York, we do it this way. So I think that is going to require some interesting conversations. you know, what we talk about, what we've always recognized, the social determinants of health, that kind of where you can address, it's got to be more than just reduce hospitalizations, reduce utilization of emergency rooms. Right now, I don't know if all of that is as paramount as the need to address, you know, and this has to do with the state's continued dance and negotiation with CMS.
Yes, that's a
And,
huge factor
and
here.
it's huge. And just, you know, the part of this budget allowed, and it had to do with the settlement, the huge settlement. Everybody was making a run for the settlement, but $850 million of the settlement was used to pay back the feds for the way that the state was using money in developmental disabilities. And I only mention that to say that that ongoing debt got in the way of a lot of our planning for the waiver. And so there's a natural built-in distrust of New York and what it wants to do. So the metrics that we think are important, are important and achievable, and what we see in terms of a public health approach, I think naturally and unfortunately clash with some of the bigger, you know, way above all of our pay grade pressures. That's just what I'm saying for now. And again, there are some of us, you know, little worker ants in there trying to make the case for certain things like the home and community-based services, how that is going to be able to really resource a lot of what we know works, but doesn't kind of, in a linear way, point to reducing hospitalizations, or it just, yeah, I would have to say that there are some bigger pressure politics and bigger pressures that are going to impact how we move forward.
Chrissy, you used the word pressure, and
Pressure.
I'll kind of not to add in another pressure or another kind of words, but kind of just on the, like in the big picture, and Dr. Rokin, you should also weigh in. I mean, we're clearly the train has left the station in terms of we're not, you know, in terms of things are moving to a managed care system. You've got the district, you've got the PPS, you've got the hub, you've got all this activity happening. The pressure question is, I don't think it's too late, obviously, for a lot of the innovation to kick in, but how much time do we have? And so it is moving very fast. So where does it start to get to be that, you know, oops, we passed that stop? I don't know if it's that linear as yet or not, but where we've got a lot to do and a lot of it is happening as we're doing it. But do we as funders need to think that, well, you know, if we're coming back to, well, this is planning for end of 2016, where we could think about this, is it too late? Where is it?
I definitely hear a sense, or the sense of urgency around the next 2 to 7 years, right? 2 years being very much kind of a grace period of time in terms of what the time that the state is being given to put things into place.
Okay.
There's also that what the state can look forward to not having to fund solely anymore, and really be able to draw down on that federal shield. And then some more of the MRT planning, looking further down the road, and, you know, continued engagement with CMS. I don't know, in my 3 agencies, I don't know like the full scope of details as of yet. But that's definitely the sense of 2 to 7 years is kind of.
I mean, that is helpful, because I think, you know, we all are, you know, obviously July is big, but
July's big.
you know, there's more than July. I mean, even we don't get to everything, there's other stuff that can happen post July, obviously.
Although just, you know, just to the extent timelines, don't get too don't get wedded to them.
Yeah.
It seems, certainly it seemed like about a year ago, there was so much changing and like moving target that it's just, these are just framework.
There's that little room in Washington where June might make a huge difference, right? On what those.
If I could just add, I think now is the right time, and in fact, earlier would have not been a good time because, all that's happened is some groups have formed and created bylaws and stated some projects that they're going to do, and we picked some plans to manage care at the same rates that they've been functioning with some more services. The action really isn't going to happen until, you're right, I think in the next 2-year time frame we'll start seeing some of these things moving. And I think that's really the time for what I describe as purposeful vigilance. I've been focusing on, can I build the structures that will have our nose deep into knowing what's going on, and working with the state to create a mechanism where we meet regularly and look at the same data and talk to each other about how happy we are with plan performance. So it's sort of setting that table, and I think then the lights turn on and those parts move. But I think that the key areas will be the sorts of things I mentioned is how do these networks really work and really involve the non-medical center-based activities and support them and really rationally connect them up in a pathway, not just in some further fragmentation. And the capacity locally, both in the community and in the local government, to keep an eye on it and manage it. And those, I think, are the degree either of those things happen well is the degree this goes in those directions. One urgency I had about putting out. So, we obviously have an administration now that cares about mental health and is putting it more front and center than I think any administration ever has, ever. So when sort of asked, well, what should we focus on? I said, focus on knowing what you want to focus on. And that's what we're doing. And so I think this comes in very timely. So I would say, if you ask what I want from the state, is don't do anything that doesn't advance one of those things. And if it doesn't meet that test, then we're heading in the wrong direction. So if the indicators that we hold plans accountable to don't let us know if those things are happening, then we have the wrong indicators. And they don't even have to be the contractual indicators. They at least have to be indicators that we agree with the state that we care about together. And that conversation is happening. This is new for them too. Yeah, this is new for these guys too. And I think a lot of the work has been on getting the plumbing assembled. And now, to push this metaphor, now when we turn on the water, it's going to be a different ballgame. But if we don't have a North Star, I think that's what makes it harder.
It is my obligation to mention that we are 2 minutes over already. So I think we can have some more private conversation afterwards, but I think that we need to officially bring this to a close. I would just like to say that a small group, but I think it's a group that is fairly closely following this, and I think that just on the very basic level, it is really encouraging to me that we did this, had this discussion, because to me it says that there are lots of areas and levels for leadership in this area. The state has leadership to play, the city has leadership to play, all the organizations in the community have lots of levers that they can pull and can be playing, and I think philanthropic organizations really have some potential to play helpful roles. I'm not entirely clear at this moment from this conversation what those are, but I know that they exist for sure. So do you want to say anything? You look like you want to say anything.
I think to be determined.
Okay, and Irfan, do you want to say something in closing?
No, just thank you, and I think it. I appreciate the candor and the honesty.
Yes, very
This
much
is
so.
a difficult,
Both of
often
you.
stuff to talk about, but I know I really appreciate it because we talk a lot we talk a lot with folks, but having this capacity to do this, I know, and I think I speak on behalf of other folks in the room. It was really good.
My one thing that I would add is older adults. I didn't hear a lot of that talk, but we talk about HIV, we're funding programs for older adults who have HIV. We talk about people leaving the prison system, we're funding projects.
Aging was supposed to be in my portfolio, and then it's been,
But
you know, it's all of it. It's all of it.
Yeah.
It's all of it. It's absolutely.
And, you know, you add on all those things from stigma to chronic disease, all that, and then you add on the mental health issue, you know, and you're older and you don't speak English and all those things, it just makes it that much more difficult. So I just, that's very vulnerable and right utilizing the population.
Yeah, absolutely.
Thank you.
Thank you.
Yeah.
So,
Yeah.
40 hours here.
Okay, okay.